Hello, everyone. Hope you're all having a fantastic week thus far. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to welcome you to today's webinar. We're joined today by a multidisciplinary group from Northwestern Medicine who is here to share with us their experiences with a double lung transplant on a patient who suffered post-COVID fibrosis. I know we're all eager to hear about their perspectives, but before we go ahead and begin today's program, I'd like to take the next minute or so just reviewing a quick notes and reminders. Now, as you may have noticed, we have recently transitioned to a new webinar platform. So we hope you'll all join us in our excitement to launch this platform, as it is our hope that this will ultimately provide you all with a more engaging and user-friendly virtual learning experience. Now, similar to our webinars in the past, we have muted all of the participant audio lines to ensure that we have the best audio quality for our presenters. That said, please take note of the Q&A feature that's located in the Zoom navigation bar at the very bottom of your screen. All of our questions for our presenters should be submitted here. Once the presentation has concluded, we'll go ahead and transition to our Q&A discussion, where our presenters will address as many of your questions as time allows. Now, for anyone interested in our upcoming webinars, please note that registration is currently open for our next innovation-focused webinar, Planes, Drones, and Automobiles: How Unmanned Aircrafts May Be a Solution to the Organ Transport Challenges of COVID-19. You can join us for that on December 3rd at 2 p.m. Eastern. Now, registration is also open for our very first webinar of 2021. I can't even believe we're here, but here we are, where we'll review the past year and what adapting to the COVID pandemic has taught us. You can be sure to join us for that on January 12th at 2 p.m. Eastern. Now, for more information on all of our upcoming webinars and to ensure you have the latest information, please be sure to check our website at organdonationalliance.org. Now, following the conclusion of today's program, you are all eligible to claim continuing education credits. For this webinar, we are offering 1 nursing contact hour, 1 CEPC credit, and of course, a certificate of attendance for anyone desiring CEs that may not be available. Prior to receiving your credits and certificates, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to claim your credits and certificates. Now, as an added note, we would like to take this opportunity to advise you of the graphic nature of some portions of today's presentation. While we understand that majority of our viewers are seasoned healthcare professionals, we always like to provide this disclaimer and do still advise viewer discretion. Now, without further ado, I'd like to go ahead and begin today's program by introducing our moderator and mastermind behind today's presentation, Kristen Combe, Manager of Operations of Thoracic Surgery at Northwestern Medicine. Kristen, it's such a pleasure to have you with us today. At this point, I'll go ahead and turn it over to you to introduce our presenters.
Thank you, Deanna, and thank you to the Alliance for inviting us to speak today. We're so excited to share what we've been through and what we've experienced and what we've learned with the rest of the transplant community. And thank you to the transplant audience who's here to listen to our stories as well. I want to start by introducing our first speaker, Dr. Michael Ison. Dr. Ison received his medical degree from the University of South Florida College of Medicine and his master's in Science and Health Evaluation Sciences from the University of Virginia. He's been at Northwestern since 2005, working in infectious disease. He's involved with a number of transplant organizations, including the International Society for Heart and Lung Transplantation, and the American Society of Transplantation, and the TID section of the Transplantation Society. Dr. Ison has received numerous grants and has widely published on the topics of infectious disease and transplantation. His research interests include influenza and viral disorders in the immunocompromised host. Dr. Ison?
Wonderful. Well, thank you very much for the opportunity to present to you today. Let's see, there we go, there are my slides. These are my disclosures. So what I hope to do very briefly in the next 7 to 10 minutes is talk briefly about the current epidemiology of COVID-19, options for prevention, especially now that we have some great vaccine options, and what we know about treatment. Unfortunately, we're seeing a significant uptick in the number of COVID-19 cases, not just in the United States, but globally. And this is clearly of a great concern. In fact, for many parts of the country in the United States, we're seeing rates of disease that far exceed the number of cases that we've seen during the first waves of disease. We in Chicago are definitely in the epicenter, but much of the country really has significantly rising rates. These numbers are a few days old. We're over 11 million cases and just topped 250,000 deaths, with just shy of 80,000 individuals being hospitalized. This is data looking at the age of distribution of patients based on diagnosis, and this is representative of what we're seeing around the country. The majority of individuals that are developing COVID-19 are young, with over 60% of patients being 50 years of age or younger. This is important because these individuals may have mild or asymptomatic disease, and therefore, since they don't have much in the way of symptoms, may inadvertently transmit infection to other people with risk factors, particularly as this population may be more likely to go without masks and more likely to travel and engage in riskier behaviors like going to bars and eating outdoors. Unfortunately, they can cause infections in older adults, which thankfully represent a very small percentage of cases, but unfortunately represent about 80% of fatal cases. And this is why it's really important, irrespective of your age, to be thoughtful of others, wear a mask, stay socially distanced, and minimize exposures to others. A key thing that we've come to learn is that while there are a number of underlying medical conditions that are associated with an increased risk of disease, kidney disease, obesity, diabetes, and hypertension being some of the diseases with the greatest association with risk of hospitalization and death, it's actually the number of these comorbid conditions that significantly increases your risk for hospitalization and death. The more comorbid conditions, the more likely you are to become very ill. We've also learned that COVID-19 disproportionately affects the African American and Latino populations in the United States. Not only are they overrepresented in terms of cases, but they're far overrepresented in terms of hospitalizations and deaths compared to the overall population. This is important because while genetics may be a component of this, there are other factors contributing to this disease, including healthcare issues, a higher rate of comorbidities, access to healthcare, and other challenges to these populations. As I mentioned, perhaps one of the most important factor for severe disease is obesity. And the reason why I highlight this is people that are overweight, myself included, oftentimes don't view themselves as being at risk or as sick. But for this disease, it's probably the #1 risk factor for having severe and progressive disease. And so I think it's time that you look yourself in the mirror and recognize that that little bit of extra padding may be risk for severe disease. While initially patients may have mild disease, oftentimes classic symptoms will develop. Loss of taste or smell oftentimes predates some of the other symptoms that are classically associated with COVID-19, including fever, nausea, vomiting, muscle aches, and difficulty breathing. Unfortunately, unlike many illnesses that once you recover, you are back to normal, a large number of patients that develop COVID-19 will have persistent symptoms. This is particularly true for things like fatigue, shortness of breath, aches and pains that may be present in up to 40% of individuals after they've recovered. In addition, we recognize now that this virus causes damage to the heart, lungs, liver, and kidney, and this may predispose individuals with these infections to having earlier onset of liver disease, heart disease, lung disease, and kidney disease. We've recognized in terms of preventative strategies that masks are probably the most important factor to protect us and others from transmission of COVID-19. But there are some settings where it's either challenging or hard to wear a mask, such as in a restaurant where you have to eat, you can't eat with your mask on. Bars and coffee shops, again, people spend long periods of time there without their mask on, enjoying their beverages. Depending on ventilation, things like gyms and churches and other religious gatherings, particularly if there are a high number of people in the facility, can be associated with an increased risk of acquisition of disease. All of us have been praying for a while for vaccines, and thankfully we're starting to get some useful information coming down the pike. The majority of the vaccines that we've been hearing a lot about, the Moderna and Pfizer vaccine, are RNA-based vaccines. So basically these take pieces of the genetic code that codes for the spike protein. These are injected into the muscle where they make the cells produce the spike protein, which triggers our immune response and protects us from infection. The second set of vaccines, which represent the companies just behind Moderna and Pfizer, the AstraZeneca and Johnson & Johnson vaccine, use a very similar technology, except they use an adenovirus to put the genetic material in the cells. The last types of vaccines that are a little bit further on or further behind in their development, but are in phase 3 or advanced stages of testing, are things that use proteins, either inactivated viruses or traditional protein vaccines like our flu vaccine. These are much more challenging to produce, and so they take a little bit longer to develop, and this is why they're lagging a little bit behind. So we've heard some very useful things out of the two lead vaccines, the Pfizer vaccine, which requires 2 doses over 21 days. The data that's been presented shows that it's 95% effective with similar efficacy in patients that are older than 65. So this is really an exciting bit of data, and most of the cases of severe disease occurred in patients that got the placebo vaccine. Similarly, the Moderna vaccine also requires 2 doses of vaccine. This one's dosed 28 days apart, has also 95% protective efficacy with all of the severe cases in the placebo arm. Both of these vaccines are pretty safe, and really the main side effects that people experience are the same side effects you experience when you get your flu shot. So just local site infections, aches and pains, and a little bit of fatigue. The real challenge, though, is although we're on the cusp of having these available, not everyone is going to be able to get the vaccine on day 1. There's a strategy for prioritizing who gets the vaccine first. It'll be really frontline workers in the healthcare industry first, then patients with 3 or more comorbid conditions or in overcrowded settings like nursing homes. Phase 2, which will probably not get started until March or beginning of April, really is where essential members of the commercial side of things, teachers, grocery store workers, delivery workers will get their vaccine, as well as people with fewer healthcare conditions. Phase 3 and 4 are patients with underlying conditions but milder conditions, and phase 4 being the otherwise healthy population. It's likely going to take us till early summer or sometime in midsummer before we really get the entire population vaccinated, if they're willing to get the vaccine. Lastly, we've had a lot of work done on treatments and currently have 3 types of treatments that have been shown to be effective. You have antiviral medications like remdesivir. You have anti-inflammatory medications such as dexamethasone. Both of these are useful mainly in hospitalized patients. And then you have antibody-based therapies like the monoclonal antibody that recently got emergency use authorization, which are really more geared towards prevention of very severe disease in patients that are outside the hospital. So with that, it's been an honor to talk with you about some background data, and I'll turn it over to Kristen to introduce our next speaker.
Thank you, Dr. Ison. Our next speaker is Dr. Ankit Bharat, who's Chief of the Division of Thoracic Surgery and Surgical Director of Lung Transplant and the Lung Rescue Program here at Northwestern. Dr. Bharat received his medical training at Christian Medical College in India, following which he joined Washington University in St. Louis. There, he completed his general surgery residency and cardiothoracic fellowship, as well as postdoctoral research fellowship. At Northwestern Medicine, he treats patients with advanced thoracic diseases and provides therapies such as lung transplantation and extracorporeal membrane oxygenation to those with end-stage lung failure. In addition, Dr. Bharat provides minimally invasive treatment to patients who patients with thoracic malignancies, including robotic and video-assisted thoracoscopic surgery. His research interests include using his basic science laboratory to investigate immunopathogenesis of lung disease with a focus on transplant immunobiology. Dr. Bharat? I think you're still muted, Dr. Bharat.
No, I think the administrator just unmuted me. Thank you for the opportunity. And Kristen, thank you for introducing. I think this is probably Dr. Tomic's presentation. Can someone pull up my presentation?
Correct. I don't know if I'm unmuted or not, but this is my presentation.
Yeah, we need, yeah. Okay, great. That's mine. So I'll briefly share with you the experiences we've had with regard to the surgical care of these patients and some of the research efforts that we've made to try and address clinically relevant questions in the context of providing lung transplant care to these patients. So this picture on the title slide is something I'm quite proud of. It'll become a little bit more relevant down the presentation, but it really shows your normal human lungs using a new technique that we've developed in the lab called matrix imaging. Essentially what this is we take the human lungs and we make it, we treat it so that the light can pass through it. So you can see through the lungs and the structure. It's like, some of us have witnessed, these bookmarks. They used to be leaves and you take the chlorophyll off the leaf and you can see through the leaves. So it makes the light pass through it and you can really see through it. So what this demonstrates is the collagen deposition and how the matrix or the fundamentals of the lung is. And once that gets destroyed by pathogens, the lungs don't tend to recover. Anyway, so with that background, let me move to the next slide. I don't think I have control of this. If I could get control of the presentation, that'll be great. All right, so lung transplant was developed not too long ago. Dr. Joel Cooper, 1983, did the first double lung transplant. And Dr. Alec Patterson, one of his mentees, is credited for performing this first double lung transplant in 1986, both in Toronto, and then they came to WashU, and I was privileged to be trained by them, and then come to Northwestern. Now, lung transplant, after their efforts, has become quite a standard technique for a number of different conditions at centers all over the world, including our center. So this is just a representation of 2 transplants we've done in the recent past. The top one is emphysema patient. You can see how black these lungs are, and the picture on the right shows you how the normal lungs look like. The one in the bottom demonstrates a patient who has scleroderma and pretty severe pulmonary hypertension leading to heart failure. And you can see how the heart is struggling prior to the transplant, and then immediately after transplant, when you put the normal lungs in, how nicely it's contracting and how robust it is. It's no surprise that the lung transplant is growing across the globe, and this slide from the ISHLT is reflective of the growth of lung transplant. And when you look at the common indications for lung transplant, those are also growing every year, but the 3 most common indications are emphysema, represented in green, ILD in this bluish purple, and then cystic fibrosis, although there are a number of other indications like sarcoidosis, alpha-1 antitrypsin deficiency, pulmonary hypertension, and such. Now, one of the things that is not considered traditionally is not considered to be an indication for transplant is acute respiratory distress syndrome. And certainly permanent lung damage resulting from infectious pathogens is not traditionally considered lung transplant. And the reason behind that is the following. So the medical community has generally observed that patients who've been on ECMO, which is the heart lung support device, um, um, necessary in some patients who have lung failure, they don't tend to have good outcomes. Or patients who've been in the hospital for a while, who've had a number of complications like pneumonias and or who have frailty, who are deconditioned, they don't tend to have great outcomes compared to patients who come in with established end-stage lung disease from their home, having participated in rehab. Now, having said that, if the one-year survival of patients who've had the standard types of end-stage lung disease, about 90%. When you look at patients who've been on ECMO, who've had a number of other conditions, can vary anywhere from 70 to 85%. So it's low compared to the standard patients, but it's not dismal. So recently, a Korean group had published this paper looking at lung transplant for patients who've had ARDS, and most of these patients had ARDS from influenza or other types of infectious pathogens. And these patients, at the time they were considered to be listed for transplant, uh, um, were at the point that the institution was going to withdraw care on them because lack of any other treatment options. So you take potentially some patients who had no other option and their mortality is approaching 100%, you transplant them, and then you look at what their survival is at different time points after the transplant. And at 1 month, they demonstrated 100% survival, and at 3 years, they demonstrated about 78% survival. That's quite impressive in my opinion, because again, as I mentioned before, these patients had no other option and they would have died. So you take someone with 100 or 0% survival and you improve it to a 3-year survival of 78% is quite dramatic. So when we started to get hit by this pandemic, we hypothesized that while patients who've had a number of complications and who've been on ECMO and ventilator for a certain duration of time prior to the transplant, while their outcomes historically have not been shown to approach those that have the standard lung transplant, um, even if that was 70 to 80% range, if we take at least a subset of those patients and transplant them, we would be able to take their survival from 0% to about 70, 80%. So, and then also the second thing that we had observed was during this pandemic, we saw a number of patients who are otherwise had been relatively healthy or with minimal to limited comorbid conditions, and they developed this COVID, and then they developed ARDS and progressed to irreversible lung injury despite best medical treatment at that time, and they had no other option. So we felt like these patients were healthy a month or 2 months or 3 months ago, and if we were to fix their lungs, because at that point at the time of consideration of transplant, they had only single organ failure, we should be able to get them back to their baseline. So we have performed 7 transplants, although we've evaluated a number of additional patients, but the 7 transplants we've done, this is their very kind of simple demographic profile. We've had both males and females. The age group has varied from 28 to about 66, all different races, Caucasian, Latinx, Black. All of these patients were on ECMO, and they have been supported for a pretty long duration of ECMO and mechanical ventilation. So in fact, our second patient was on ECMO for 100 days, which is the second longest in the world after South Korea. So we have supported these patients for a long period of time, and part of the reason was you want to give these patients enough time for the lungs to recover and establish that the lungs are not going to get better. If you pull the trigger for transplant too early, you could potentially redirect the pathway from lung recovery to lung transplant, and that's not in the best interest of the patient, obviously. So this is our first patient, and she's been in many different news outlets. So I'm at a liberty of sharing her case profile now with her consent. So she was a 28-year-old lovely woman with NMO, neuromyelitis optica, which was well controlled. And she presented end of April with end-stage lung disease, with COVID pneumonia, which progressed to severe ARDS, goes on to developing a need for ventilation, a mechanical ventilator, and then was placed on ECMO soon after, and had a number of complications with nosocomial pneumonias, kidney injury, liver problems, etc. And she progressed to permanent lung damage. And this is the progression of her x-ray. You can see how she came with a little bit of infiltrate on the left side that progresses to both sides. Here it's continuing to progress, complete whiteout by 2 weeks, 14 days on after the onset. And then by 21 days, you're starting to see this development of necrotic cavity, which was then infected by this multi-drug resistant serratia infection. And then just prior to the transplant, you see a complete whiteout of the right side, and then pretty significant necrosis of the left side with a lot of these cavities being developed. So at that point, it was clear that she was not going to get better. And in the light of all these potentially lethal complications, we needed to transplant her to save her life. She received all the standard treatments at that time, including hydroxychloroquine. Again, this was, many months ago, remdesivir in a trial, and then plasma and IL-6 inhibitors that were being trialed at that point. And she received ECMO and this mechanical ventilation based on the standard of care. Ultimately, she didn't get better, and she underwent a lung transplant on June 5th, 2020. I've shown you some pictures from the operating room. So this is halfway through the operation. You see the new lung being implanted, the right lung, how different it is. And in contrast, you can see a lot of these cavities and blebs that develop in it, and I'll kind of highlight that in the explanted lung tissue. This is after both lungs have been implanted here, working well. On the explant pathology, what we've noticed in a majority of these patients is development of these necrotic cavities all over throughout the cut surface of the lung. And this is visible in the second picture on the bottom. And we think this is from necrosis of the lung. Another common feature is the development of these microthrombi in these lungs, which can make the lungs quite ischemic, make them essentially die in parts, and then that gets colonized by bad infections. So this is her now, post-op day 10. She was doing really well. 17, she's up working with physical therapists, and this is just from a few days ago. She is preparing for a run, and it's quite remarkable how in 5 months from being almost dead to being quite independent and running a mile almost, doing fantastic. She could probably beat me at this point. So it does work in some patients, and it should be considered for some patients who have permanent lung damage. Now, in the last couple of slides, I just wanted to highlight a few things. So this is a busy slide, but I'll just point out a couple of things. So compared to the non-COVID transplants that we've done during this time, the comparison of the first 3 transplants with regards to surgery is the following. So it does take much longer, so about 10 hours per surgery compared to about 6.5 hours for double lung transplant. In a non-COVID setting, they require a lot more blood transfusion. So normally we use 1 or less units of blood, but on average, we end up using about 10 units of blood for COVID lung transplants. All of these patients do require heart-lung support in the form of veno-arterial ECMO or full bypass, and they tend to stay much longer on the ventilator after the transplant, so 12 plus days compared to only about 4 days. So definitely have a much more difficult operation and prolonged recovery, but they do get better. All these 7 patients that we've transplanted, they've been alive they're actually doing well. They've had at 30 days, similar to the South Korean paper that I mentioned, it's 100% survival. And most of these patients are off oxygen already. Finally, a couple of questions that we needed to answer is there, how can we be sure that the virus has cleared from their body, and will it come back? So all these patients were tested thoroughly in consultation with our ID colleagues and obviously our transplant team, and we use multiple negative PCR, at least two days or 24 hours apart, to make sure that they're cleared. And then we validate that using a new technique called for this purpose called RNA scope. So here on top, I've shown you two pictures from autopsies of patients who had died with COVID. So the yellow dots represent a virus, and then the green dots represent a replicating virus. These are just two controls here on the top. And then using that in the explanted tissue, we can make sure that the virus is gone. So we did not detect any virus in any of the explanted tissues using that RNA scope technique. And this is interesting because one of our patients was negative for a long period of time, and then after the transplant was detected, was found to have a couple of positive tests. So it was reassuring that their explanted tissue was negative for virus, so we can be a little bit more certain that the positive test was likely a false positive or from prolonged shedding or something. And then going back to the matrix imaging that I showed you, this is actually was very important for us. So this is a normal lung, just that same matrix imaging that I showed you. It looks a little haphazard, but it just shows you that the lung is a very a complex organ with a closely knitted collagen structures. But when you compare that to COVID lungs, there is that framework is lost. I mean, the whole lung is just basically bag full of pus and inflammatory cells. So when the framework is lost, the lungs don't get repaired. So these are all just different pictures of COVID lungs. And the bottom right is an IPF lung, which shows somewhat preserved structure, but they're very thinned out and they're nearly gone. So these lungs tend to have very severe damage, and they are not likely to get better. This is just a three-dimensional view of that. We actually, just to avoid any imaging artifacts, we want to show you like a three-dimensional rotational view. So this is how the lungs, normal lungs look like. You can see how in 3D it has that framework. So even if there is an injury and you have loss of epithelial cells and endothelial cells, as long as the framework is intact, the lungs will get reepithelialized and recover. But once you have something like this, which is seen in the COVID lungs, the framework is lost, so the lungs don't get better. We now have been working on trying to figure out how do we predict whether patients have gotten to the point of no return, because obviously the imaging that I showed you requires evaluation of the explant to a large extent, or a big biopsy, which may not be feasible in some patients. So we have used a lot of state-of-the-art tools, including single-cell RNA sequencing. And I'm not going to bore you with the scientific details of this, but basically what we found is we've identified these specific cells called, they are KRT17 positive cells, which are usually located in the proximal airways. But in patients who have COVID, you start to see emergence of these cells in the very distal airways. And this is a common feature in IPF. So long story short, it does represent a differentiation defect between AT1 and AT2 cells. And we think we can use this to differentiate someone who needs lung transplant versus someone who's going to get better. So after we've done the transplant, number of other centers and countries have done it. These are the centers who, these are the different countries that have been successful in doing COVID lung transplant: China, Austria, United States, South Korea, India, and most recently, Mexico. Thank you.
Thank you, Dr. Bharat. I think we're going to go back to Dr. Tomic's slides here. So Dr. Rade Tomic is Associate Professor of Medicine here in Pulmonary and Critical Care Medicine here at Northwestern University. Dr. Tomic completed his medical education at the University of Zagreb in Croatia, followed by his residency at University of Illinois at Chicago and fellowship at Emory University in Pulmonary and Critical Care Medicine. Dr. Tomic is double board certified in pulmonary medicine and internal medicine, and is most known for his research on interstitial lung disease and lung transplantation. His research interests include investigating photophoresis as a treatment for chronic rejection in lung transplant recipients. Dr. Tomic is well published on the topics of lung transplantation and pulmonary fibrosis and other interstitial lung diseases, and is involved with several professional organizations, including the International Society for Heart and Lung Transplantation, American Thoracic Society, and American College of Chest Physicians. Dr. Tomic?
Thank you, everybody. It's a pleasure and an honor to have opportunity to present on this forum. So I'm going to talk about lung transplantation during this pandemic and how the pandemic affected the transplantation world in general. So I just want to show you some of the numbers, how the transplantation world was affected with pandemic. Across the world, numbers are drastically down. You can see that in France, during the first 3 months of pandemic, deceased donor transplantation was down almost for 100%. Lung transplant in the United States decreases by around 40%. On the other side, there is a 12% increase in waitlist mortality as a consequence of decrease in the number of the lung transplants, and availability of deceased donor is increased. There are multiple risks now associated with doing a transplantation about time of the pandemic. Some of the risks are obvious and mentioned here. It's a possible transmission to the staff, a problem with coordination between the ICU and transplant coordinators, risk of exposing recipients to immunosuppression, paucity of supplies and a lack of available supplies during the height of the pandemic is the big problem because we are competing at the same time for the intensive care beds with COVID patients. And informed consent is somewhat poorly defined risk stratification at the time, especially on the beginning of this pandemic. However, lung transplant is the life-saving procedure, and any decision to restrict or liberalize lung transplantation should be centered on the overall patient well-being. Another important factor to consider is prevalence of infection within the community, capability of each centers to manage the workload, and to maintaining ability to maintain infection control procedures. And as always, it's very important to respect patient and donor autonomy. Some of the practical implications of doing transplants at the time of the pandemic, we are now screening donors and recipients. A bronchoalveolar lavage is preferred method of the screening of the donors. CT of the chest for the donors are very much welcome, looking at the specific pattern of the COVID infection. And generally for recipients who are highly sensitized, it is recommended to postpone desensitization because this recipient will be potential recipient will be additionally immunosuppressed at the time of the pandemic and at risk, higher risk to get infection. However, highly sensitized patients should be prioritized if reasonable match is available at the time of this pandemic. There are a lot of questions about immunosuppression at the time of the pandemic and the patients who are currently immunosuppressed, who are currently already recipient of the lung transplant. Some of the practices extrapolated from the managing of other viruses. Probably what is recommended, there is no need to alter immunosuppression for the milder infections. And the first agent that probably should be altered is antiproliferative drugs, and they are most frequently decreased in the patients with COVID infection. Some of the studies show that converting from tacrolimus to cyclosporine was beneficial for the recipient of the lung transplant. And another consideration for this population is in pharmacokinetic interaction between the immunosuppression agents and antimicrobials. It's a questionable effect of especially CNIs, so calcineurin inhibitors on the immunosuppression and viral replication. It is deemed that immunosuppression with CNIs will prolong viral replication. And what is also interesting, it is noticed that, especially in the earlier studies, that inflammation as well as interleukin-6 was decreased in the lung transplant recipients. And we have our own very interesting experience. We have from the patients who are equally immunosuppressed that are completely asymptomatic to, unfortunately, one patient, one case of the lung transplant patient with COVID who died. So, at the time of this pandemic, each center chose their own strategy, how to approach to the lung transplantation. And this is experience from Duke. As you can see here in 2020, actually during the height of the pandemic, they have the highest numbers of the lung transplant in comparison to the previous 4 or 5 years. Similarly to that, in our center, we also increased the number of the patients during the time of the pandemic, and we did that on the safely manner in the both centers. For the both centers, there were no difference in the type of the donors that we are accepting. In the Duke experience, they didn't have any infection after the lung transplantation with COVID in their recipients, which were done from March to June. We have one patient who was infected with COVID. As a negative donor and recipient test, as we mentioned before, minimal requirements, and recommendation that all transplant recipients should be in the single ICU. What is crucial is really multi-institutional collaboration, which is help to limit procurement travel and maintain provider health and safety. Risk of the COVID-19 should be also incorporating in the regular risk-benefit determination associated with lung transplant. In the few next slides, I'll a little bit switch gear to review the current available knowledge about currently transplanted patients who were transplanted for actually COVID-19 pneumonia. So this is the first 3 patients from China. You can see their imaging is typical for the COVID. And in their population, the oldest patient was 73-year-old. All patients were negative for COVID-19 at the time of the lung transplant. And all cases were done on the VA ECMO in the OR, and patients were supported postoperatively in ICU with a VV ECMO. They used the lower dose of the calcineurin inhibitors postoperatively, and unfortunately, one of the 3 patients actually died. When they were looking at who is the ideal lung transplant candidate from the patients with COVID-19 lung failure, they want to establish that there were definite irreversibility of respiratory failure. All patients had confirmed negative PCR status prior to the lung transplant, and all patients have a single organ failure, meaning just the lung was the only organ which failed. Austria was the first country in Europe who did a lung transplant for the patient with COVID, and their experience was somewhat different. This is the patient prior to the lung transplant in imaging and post. And they actually transplanted a patient who was a PCR still positive, but a viral culture were negative. Patient was unable to give consent because patient was deeply sedated. They actually did desensitization prior to the lung transplant because patient was highly sensitized. And case was quite complicated in the OR. They used 30 units of PRBC and 5 units of platelets. Similarly, as in Chinese experience, they use intraoperative VA ECMO and postoperative VV ECMO. They utilized the standard immunosuppression. However, patient developed very early AMR, which was treated with including the ATG agents. And the patient was transferred to the floor after 63 days in the intensive care unit. Interestingly, also, patient was positive for COVID-19 up to the 10 days post-op. Canadian group from Toronto recently proposed criteria for the consideration of the lung transplant in the patients with COVID-19. They recommended that patients should be younger than 65-year-old. They should have a single organ failure. And they recommended at least 4 to 6 weeks period after initial signs of respiratory failure before consideration for the lung transplant. No other contraindication for the lung transplant should be present, meaning body mass index or any other infection, unusual infection or multi-drug resistant infection should be not present. They advocate for negative PCR prior to the transplant. And they recommended that transplant should be done in the centers with experience with high-risk transplant, as well as in centers who have very low waitlist mortality. In other words, shorter waiting time on the lung transplant list. And they also recommend that patients should be awake and able to discuss lung transplant options prior to the listing. I will finish briefly with our experience about lung transplant that Dr. Bharat was talking about that mostly suggest in a few words. All our patients are currently alive. None of them were on VV ECMO post-operatively. Unfortunately, one went repeatedly into ICU after the lung transplant, but 5 of them are out. And we are leading center in the US and across the world by the number of the lung transplantation. I will be happy to answer on any question, and thank you for the opportunity to present.
Thank you, Dr. Tomic. Next, we have our panel of multidisciplinary participants that I'd like to introduce once we pull up their slide here. Here we go. Mike Bielaczyc is our lung transplant clinical social worker. He's earned his master's degree in social work at Jane Addams College of Social Work at the University of Illinois in Chicago in 2011. Prior to joining Northwestern Medicine, he provided services to individuals with serious chronic mental illness as an intake coordinator and psychosocial rehabilitation caseworker. He has been a social worker at Northwestern Medicine since 2011, providing discharging planning to general medicine patients until 2015 before joining the lung transplant team. He's currently a certified clinical transplant social worker and provides psychosocial assessments and services to pre-transplant and post-transplant lung transplant patients and their families. We also have Jennifer Wright, who's lung transplant nurse coordinator. She received her Bachelor of Science in Nursing degree from the University of Wisconsin-Madison and recently received her Master of Science in Nursing from Loyola University in Chicago. She has over 12 years experience caring for transplant patients across different organs and throughout the continuum of care, including pre-transplant, post-transplant, and living donor care. She's been with the lung transplant team at Northwestern Memorial Hospital for the last 5 years, caring for pre- and post-transplant patients as lung transplant nurse coordinator. Jennifer is a certified clinical transplant coordinator and has also received her certification in quality and safety improvement. She is involved with Sigma Theta Tau International and NATCO, the Organization for Transplant Professionals, and has several peer-reviewed published articles and presented abstracts in topics in transplant. We also have Sanket Thakkar, who is our ECMO coordinator. Sanket received his Bachelor of Science degree from Southern Illinois University in Healthcare Management and is a registered respiratory therapist with specialty in adult critical care. He joined Northwestern Medicine in 2006, where he has held roles as advanced practitioner, clinical specialist, and clinical coordinator for respiratory therapy. Sanket is currently working as the respiratory ECMO coordinator, where he is responsible for advancing ECMO programming and training for the rapidly growing ECMO program. Sanket and the ECMO team successfully completed Northwestern Medicine's first ECMO transport in spring 2020 as a result of COVID-19 and continues to look for new opportunities to advance care in the critical care population. And lastly but not least, we also have Jeff Lysne, who is our lead organ procurement specialist. Jeff earned his Bachelor of Science in Integrative Physiology from the University of Iowa and his Master of Science in Biomedical Science from Rosalind Franklin University of Medicine and Science. Jeff joined Northwestern Medicine Lung Transplant team in 2017 and currently is lead organ procurement specialist, where he's responsible for managing and optimizing lung transplant donors and coordinating and attending lung procurements. He also has responsibilities in lung transplant quality and regulatory data management. Having previously worked at the Organ Procurement Organization of Illinois, Gift of Hope, he has extensive experience on both donation and the recipient side of organ transplant. So to get started with our panel, I'd like to start with talking a little bit about the critical care experience that we've had. Sanket, tell us a little bit about, can you share what was initially seen when the patients were initially decannulated from ECMO after lung transplant? And how did you know that they were ready for decannulation? Uh-oh, did we lose them?
Yeah, can you hear me?
Yes, thanks.
Hey, sorry. Thank you, Kristen. Thank you, Alliance, for giving me this opportunity, and it's an honor to be part of this. Yeah, so usually every time when whenever the patient is placed on ECMO, once they are, we watch their how they are doing on the ventilator, what their lung functions are doing, how their compliance is, and then we try and do like the FDO2 challenge, the sweep challenge on the ECMO. Once we think that the the lung compliance has gotten much better, and their FDO2 requirements have gone to like 30 to 40%. We reduce the sweep to 2, make sure follow up with the ABG and everything. And then once that is satisfied, what we do is a sweep off trial for at least 4 hours. And at that point, again, we're monitoring the patient with the serial ABGs. And once they are in a good acceptable range, that's basically when we know that the patient is ready to get decannulated from the ECMO.
Thanks, Sanket. Did you notice any differences about COVID patients rather than non-COVID ECMO patients? And can you talk a little bit about that?
Yeah. Generally, with the COVID population, what we have seen is usually it's been taking them a very long time. Oftentimes, they've been on ECMO for much longer than non-COVID patient population have been. And oftentimes it's, as Dr. Bharat also mentioned, is they've been otherwise healthy, and it's like a single organ failure. So it's, and that's also been our drive, is to basically do everything that we can for these patient population, and support them in every single way. And once we see that the lung recovery is not going to happen, or is a low chance of lung recovery, that's when we've been starting to think about transplant as an option, and see if the patient would be the right candidate for the lung transplant.
Thank you. Jeff, I want to talk a little bit about procurements and what you've seen in procuring during the COVID pandemic. Can you talk a little bit about the changes in procurement that you've seen, like safety measures that you've seen, and challenges and barriers that you've come across, and if any of those things have evolved or changed over the course of the past 8 or 9 months?
Over the course of the past 8 or 9 months, I would say we've seen probably a higher number of donor offers first, especially from across the country. As we've seen, a lot of centers tend to slow down a little bit. We have been traveling to some of the hotspots in the country. However, with the safety precautions that we have taken in wearing masks everywhere, we even try to wear N95s when we can, to all the donor hospital screening, their staff as well as the donors repeatedly. Luckily, I would say it's been a very safe process. Although traveling to the hotspots of the country is not something anybody's looking to do right now. I know.
Right. Right. Have you noticed any differences among donor hospitals or OPOs, how they do their assessments of donors? Have you noticed anything about that?
Well, for a time, especially our local OPO, Gift of Hope, had chosen to restrict their use of bronchoscopy just due to the potential for aerosolization. However, they have since restarted doing bronch procedures. Almost all, well, I should say initially, testing was hard to come by in the early months of the pandemic. Not all donors were being tested. Luckily, now we're in the space where all donors are being tested at least twice, and that's no longer an issue. However, I'm sorry, can you repeat it again? Sorry, Kristen.
Just if you've noticed any changes among OPOs or differences among OPOs or donor hospitals and with the assessment piece.
And most recently now, as we're seeing an uptick in cases, we are also seeing more OPOs request that they do local procurement for us as well.
Interesting, interesting. How about, has the DRE changed at all? That piece of the assessment process?
Sorry, you cut out again there, sorry.
Oh, sorry. The DRE, the psychosocial assessment piece of the donor.
They have added a small addendum to the DRE asking if donors have come into contact with any persons suspected under suspicion of having COVID, as well as have they had a positive test recently. However, they have not covered, to my knowledge at least, have you ever been infected with COVID, which I believe down the line we could most certainly run it into donors that have previously had severe infections that have since recovered. And I'm sure all of the OPOs are doing their due diligence in that. That is just going to be something that we're going to have to learn to deal with in the future.
Thanks, Jeff. Mike, I want to talk a little bit about your psychosocial assessment. Very difficult to complete these pieces on patients who may have to have their proxy to talk for them. Can you talk about a little bit about how you are able to complete the psychosocial assessment and how that has changed over the past, since the beginning of the year with the COVID pandemic?
Sure, thank you, Kristen. And I apologize if there's a giant drilling noise that happens at any moment. It just started on the other side of this wall, so I apologize. The psychosocial assessment for most people going through a potential lung transplant evaluation can usually be 2 to 3 hours face-to-face with myself, family members, and caregivers, followed by usually several sessions of counseling and planning, both logistically as well as emotionally, for the financial, psychological, social, biological, spiritual, and existential impact of accepting a very scarce resource in the form of another person's organ. Imagine instead of doing that, the assessment is done by phone, usually with family members or caregivers that may be spread out across the country, with very little input, unfortunately, from the majority of our COVID patients, given their status cognitively and with sedation and physically. So the psychosocial assessment, instead of being based on answers and information coming directly from the patient, that at the end of the day is at the center of this, is really based very much almost exclusively on collateral information from family members and friends, if we're able to speak with them as much as I'd like to, as well as a chart review and documentation review. So it's the difficulty of doing that is, and I think Dr. Tomic touched on the concept of informed consent. We're very much taking, people's words in terms of what they know about their loved ones, which is very accurate. And many times there are things that family members and friends simply don't know about their loved one. and to be asked as a family member questions such as, do you think that your loved one will understand and commit to a very high level of compliance with a very complicated post-transplant, lifelong medical regimen? Nobody's going to say no, and I don't think that anybody should. But it's very difficult, I think, to have the same kind of confidence in an assessment when your communication with the patient that's going to be ultimately impacted by this is so limited.
Yes, definitely. Very difficult, very difficult. I think we have a few more minutes. Jennifer, I wanted to talk a little bit about inclusion and exclusion criteria. Have you noticed any aiding or hindering of patient selection because of COVID lung transplant? And what have we done, or what have you done to mitigate those factors?
Yeah, thank you, Kristen. Our inclusion and the exclusion criteria hasn't necessarily changed because of the pandemic, but certainly our ability to get all of the data we need on these patients to understand the scope of disease, or like Mike mentioned, what risk factors are out there, I feel like has been limited. Like multiple people have already mentioned, these are usually previously healthy patients. So we're usually lacking PFTs or other testing that we just can't obtain because of how high their acuity is, and likely won't obtain. So it's making the decision fully informed with the entire team that that testing isn't necessarily going to help us with their outcome. So really it's been adapting to how quickly things are changing, knowing that they may be in a limited window to see if we can allow transplant for them.
Has anything specific to COVID helped or hindered the ability to make this assessment? Like, I know we hear about the bleeding and those kinds of things specific to COVID transplant or to COVID patients. Has that hindered or helped at all?
I don't know if it's hindered or helped. I think, like Dr. Tomic said, we have just a paucity of data around COVID and transplant with outcomes in terms of having a fully informed discussion. And so it's tough to say.
Yeah, sure. Well, great, thank you. I do want to give a couple minutes to the audience. I have one question that came up so far from Bernie Kubak from UCLA. He says, thank you all, best regards to your efforts. Had the COVID lung transplant recipients received COVID antibodies? Did any recipients receive any study monoclonal antibodies during their initial COVID course? Dr. Tomic, can you speak to that? Dr. Tomic?
Yeah, I'm here.
Thank you.
Some of our patients did get plasma, convalescent plasma, and however, the monoclonal antibodies were not available for the most of the time when the patients were going. They also got interleukin-6 antibodies during the course of their disease, but that's the extent of immunotherapy that they got.
Okay, thank you.
Other participant can correct me if I'm not mistaken.
Okay, thank you. I wanted to ask the group, what's been the most surprising piece of the patient's recovery so far that you've seen? Most surprising piece, or also the most challenging piece? Anybody want to start?
I can start. I think for me, it's been kind of the shared experience of going through a pandemic together. It's impacted all of us. And certainly hearing from our patients in terms of how difficult it was, obviously getting COVID, but then being in an ICU without their family members, the very real anxiety, depression, post-traumatic stress disorder that they have come to deal with, to then being after transplant, and just what a blur that whole experience was and how tough it is to adapt to this new reality that they're in. I think that was perhaps not surprising, but striking in terms of walking through with patients that experience. I'm sure, Mike, you can speak to that as well.
Absolutely. I think this is a situation where most clinicians have very little to compare to. I think the effect of this pandemic and the stressors that our family members, we speak so much of our patients, the caregivers and family members in this particular scenario, it's very difficult, I think, to illustrate just how acutely stressful and how prolonged the stress that they live under when their family member is diagnosed with COVID, has severe complications, and then they're asked to put in place a plan that would, I think, shake most people to the core, and it affects every single aspect of our family members and their caregivers' lives. And I think we're going to see the impacts on people's mental health and their well-being. I think we're only beginning to see the consequences of that. And I'll just echo what Jennifer says, that shared sense of being impacted by the very same disease that your patients are going through is incredibly striking and very humbling.
Definitely. Thank you so much. I think we might have one more question. And this comes from Max Weeder. What was the physical performance status of the patients who were accepted for transplant and had been on ECMO for a long time? And do we have a minimum acceptance criteria?
It's a great question, and that's something that we are struggling in every day in evaluating these patients. It's we certainly would like them to be ambulatory possible, but frequently that's not the case. We have a wide range of the situations for these 6 patients that we transplanted, but what we are witnessing is very nice physical recovery in majority of the patient, and certainly that it's also related to the precondition of the patient. If somebody is young and healthy, they will recover very quickly, versus if somebody is older with comorbidities, that physical recovery will take longer time. But so we would like them to be able to definitely get out of the bed if possible, in consideration for lung transplant.
Thank you.
Yep.
Thank you.
Yeah, exactly. And that's one of the things that I was going to mention as well, is that, one of the challenging things with this pandemic is especially with the ECMO population, is that normally we try to wake every patient up and have them mobilize and ambulate whenever necessary. But now with the COVID, we want to limit the exposure. So the ambulation has been one of the biggest challenge. And so one of the other things that we've kind of utilized also is the use of verticalization bed so even if the patient has to be sedated, we try to verticalize them so that and have the physical do any type of physical therapy, and making sure that their conditioning is better before going into the transplant to help the post-transplant recovery.
Yeah, thank you. I think that ends our presentation for today. We want to thank you all very much for listening and allowing us to share our experiences today.